Hello. Okay. Good evening, everyone. Thank you so much for joining us on this weekday night uh, for our highly anticipated Meet the Specialist session. As again, we are back tonight with our Deputy Dean, Prof. Young Faridah, who's also a consultant radiologist, who's going to share her experiences with us tonight. Before Prof Young comes on board, I just like to introduce myself. So I'm Ian Lam. I'm a fourth year medical student of USC Malaya, and joining me is Vanjet. Would you like to introduce yourself? Yes.
Yeah, thanks, Ian. Hi, everyone. Good evening, and thank you for joining us for tonight. My name is Vanjet, and I'm a second-year medical student from UM. Back to you, Ian.
Okay, so me and Vanjet will be co-moderating the session tonight, going back and forth and asking Prof Young about her various life experiences as well. Of course, of her multivariate, myriad professional advice, and I'm sure that it's going to be a very, very fruitful session. So just before we start, just some ground rules to keep in check. That to remind everyone that this is indeed live on Facebook, and if you do have questions, please do leave them in the comments in the live comments in your FB, in the FB live chat box. We will get to that at the end of the session where you have a question and answer session. And also at the end of the session, please give us feedback. We are always looking to improve on our sessions to continuously make this thing sustainable and get everyone on board to learn as much as they can. And also, while we're waiting for Prof Young to come in, subscribe to our mail to get updates from our medical society as well. Okay. Yes. So for now, everyone just sit tight, and we'll have Prof Young on board in the next few minutes, and after that, we'll delve straight into it. Thanks again for joining us tonight.
Hi, everyone.
Okay, so hi. Okay, so
okay.
Hi there. Hi, Prof. So good evening. So as I've just to everyone, welcome and thank you so much, Prof Young, for joining us on taking some time off your busy schedule to join us on a weekday at 9 p.m. So just going to give an introduction to Prof Young. So Prof Young Faridah Abdul Aziz is an academic professor and consultant radiologist. She received her undergraduate and postgrad training at USC of Malaya, and she further underwent a clinical attachment in cardiac imaging in the USA in 2000 and 2001, completing the essential skills in medical education course and was awarded the ESME certificate in medical education in 2019. She is an alumnus of the IDC program organized by the German Academic Exchange Services, focusing on training academics on higher education and change management. As an academic, she is involved in developing, implementing, and ensuring quality improvement of undergraduate and postgraduate programs at UNC Malaya, and has collaborated with national and regional partners and looks forward to continuing participation in impactful research and best practices in the field of medical education. Okay, so besides serving as our Deputy Dean, Prof Young is also a consultant radiologist. She provides clinical services at the teaching and specialist hospitals of UNC Malaya and was instrumental in setting up the cardiac imaging services, utilizing CT and MRI. Cardiac imaging is a niche area of research, and she has formed institutional, national, and international collaborations and research in this area. And last but not least, Prof Young has been entrusted with numerous roles and responsibilities, not limited to duties such as program coordinator, head of department, a council member of the College of Radiology, a SETARA member under the Malaysian Qualifying Agency, and she has served as our Deputy Dean of Undergraduates at the Faculty of Medicine since 2015. She continues to this day to dream passionately, embracing the art of seeking knowledge, remaining curious, and creating possibilities in her career and her life. So, as just to sum it up, thank you so much. I'm pretty sure everyone knows about your very impressive CV, Prof. And thank you so much for joining us tonight.
No, my pleasure. I know your first question is going to be, do you use all those bikes behind you? That's your first question.
Yeah, Prof. What's with those bikes actually?
What are those? Yes. So my husband is a cyclist. Out of all these bikes, only one belongs to me. Only this one belongs to me. The rest are all his. And I have a secret to tell you that this is only like a part of the collection. He's got
Wow.
more bicycle in his room. So this is my room, my den. He has coined it the Diva Den. I don't think I'm a diva, but that's what he's called it. Yeah. Go ahead. You can grill me now.
Well, it's not a grilling session. It's meant to be a simple tea session. I'm pretty sure a lot of our students would love to understand more about what your job is, your experiences, and whatnot, which we're definitely going to delve into. The two main things tonight would be, of course, radiology and also medical education, which is, for me, I'm hearing about the first time, so I'd love to know more as well personally. So just without further ado, I'm just going to jump straight into, yes, like Prof, maybe tell us a bit about how you went into radiology. Yeah. Like,
Yes, how I went into radiology, because let me tell you, as a student, as a medical student, I was one of those that very much want to stay in the background. I really didn't want people to pick on me. So I made sure, and I've told this story before, like I'll be in the background during the ward rounds, and when I get picked up, and I'll be like, if it's a cardiology class, the answer will be left ventricular hypertrophy, and it's usually right, something like that. So I'll just throw in stuff like that. So I was not a very, I wouldn't say, I didn't, I chose medicine. I continued with it, but I didn't feel medicine so much until I did my housemanship, actually. So when I was doing my housemanship, for me, it came together. Everything came together. And while I was doing my housemanship, I did the medical posting, surgical posting, orthopedics, pediatrics. So I was exposed to a lot of the specialty. The only one that I did not do was actually ONG. But because I was in those specialty, I was also very exposed to radiology, because we used to have to go down and talk to the radiologist to ask for scans, so we had to go. So in the beginning, I went to talk to the radiologist, not realizing that I had to know a lot about the patient. So they started grilling us. And I think this is a rites of passage for the radiologist. They love grilling housemans. It's like, new ones coming in, let's give them a difficult time. And I learned so much. I felt I learned so much from them, because when you're asking for an urgent scan, they make you think about the patient, put it all together, and then it actually made me interested in finding out what the scan would look like, right? So if we think that the patient is having an cholangitis, I then started staying on to watch the scan and to get the diagnosis, So that aspect of it, I feel really made me interested. So when I was asked by my husband, he said, let's do our master's. Which specialty do you want to do? I kind of felt that probably radiology, not really knowing much about it, but knowing enough that I liked the radiologists. I felt that they put things together. And I felt that they gave that direction that was needed by the physician. So I decided to do radiology. And when I did radiology, I was amazed at how much I enjoyed it. I never enjoyed studying until I did radiology. It was really, really, it just came together for me. So, but I feel that there are certain characteristics in me that made me like radiology, perhaps. So, there are certain characteristics in all of us that maybe make us more suitable for a certain specialty. And I think with me, it's because I've always been I like to solve puzzles. So like my favorite games are Scrabbles, word game, things that you have to puzzles, like jigsaw puzzles. I've always liked those kind of things. Like looking for a clue in a bunch of letters, for example, right? So I've always been I like to solve puzzles. I also like lists. I just love, like, if you ask me for any task, the next thing you know, a pen and a paper will come out and I'll be doing like, okay, you do this first, you do this first. So I'm a very list oriented person. Like, I like to list things down. And I think that works with radiology because essentially that's what you do. And you kind of like cross out first, so you have to think of like what possible diagnosis is going to be. And then you're going to look at the patient's presentation and try to then come up with the 2 to 3 possible diagnoses, though most of the time you probably can just come up with one diagnosis. So that's, in a nutshell, how I became interested in radiology. Yeah. Does that answer your question?
Yes, definitely, Prof. I see. And it's interesting that you went into a bit about the characteristics or traits of a radiologist as well. As you mentioned, puzzle solving, even like was that having to have a list of differentials in your head? But other than that, would you say there are any other essential characteristics of that makes a good radiologist? Or
Not necessarily okay, wait. It doesn't make you a good radiologist. It just makes you want to be a radiologist.
Okay. All right.
You've got to make a difference here. I mean, it's the characteristic that makes you want to be a radiology. But of course, those are the ones that are pushing me towards radiology, correct? Also, because I think an important point, they were the people that inspired me in my housemanship. I wanted to emulate them. I wanted to be like them because I actually felt they were super clever. Like, oh wow, they can, like they put the ultrasound on and they say, well, yes, that's a gallstone. So like, oh, wow, we didn't know that. We suspected, but we didn't know, that kind of thing. So I was very, very, I felt that I was very attracted to that. And also because towards the end of my housemanship, when they knew me better, they were such a bunch of fun people, that come like, come young, let's go and look at the scan, let's go. And I did my housemanship in HKL, by the way. So mainly it was the UKM radiologist. Sorry, but it was the UKM radiologist. So when I applied for masters and asked the head of department of UKM at that time to be my referee, and when he found out I joined UM, he was so upset with me. He was like, what? I thought you're going to join UKM. Well, but that's the story. So yes. So those are the positive things that I feel in your character that will push you towards radiology. However, the things that I felt also, the negative things, meaning that I tried surgery and I tried very hard to understand surgery, to do the surgery, but I just couldn't get into it. I think personality-wise, I was not right for it. And like I'm going to be a bit of a girl here and said, I just didn't like that my hair became very flat at the end of the day kind of thing. Right? And while I had good role models in surgery itself, housemanship, but orthopedic surgery was another story altogether. I felt that they were, anyone who wants to be, these were not orthopedic surgeons now, they were orthopedic surgeons before that would, like my medical officer who's on first call, holding the first call for accident and emergency, would say to me, I want you to hold the pager because I've got to go and fetch my friend at the bus station, and just chuck the pager to me and ran off. And that's the kind of orthopedic surgeons we had in HKL. I was going like, I don't want to train under these people. So those were the push factors, the push factors. I felt that I could have done pediatrics, and the pediatricians did ask me to join them as well, because I think, the thing, but I just couldn't take that I had to be very conscientious. I had to be on my toes, and I just could not take how hard it was, right? Because you lose a patient in pediatrics, it's really, really tough. So I felt that I didn't have the emotional maturity to do pediatrics. So in the end, I chose radiology. So you have to look at the positive bits that makes you choose a specialty, but at the same time, you also have to pay attention for things that you didn't like. Because if you didn't like it during husbandship, chances are you're not gonna grow to like it. And always look out for the people that can inspire you, because if you are inspired, perhaps part of that inspiration is because how when they talk about the job, they're passionate about it and it resonates with you. So you've got to look out for that. Yeah.
I see. Prof, it kind of makes me, it sounds like it's something along the lines of that we don't realize our dreams by ourselves, but it's like it's the people around you that makes you realize your dreams.
Yeah, well, granted, I mean, there are some of you who have already decided I'm going to be a cardiologist. Some of you know your passion very early, but I suspect most of you are going to be like me when I was a medical student. Like, I just want to get through the 5 years because nothing really spoke to me at that time. But it will come. That's what I'm trying to say. It will come. You don't know when it's going to come. You've got to keep your mind open to it, keep your hearts open to it. And that's going to be a little bit of and I've mentioned this before, if you've been to my other lectures, this leap of faith that it's going to be all right. You know, it has to be there. This leap of faith has to be there. Yeah. So that's it. How I chose radiology. I have no regrets at all. I really enjoyed my master's in radiology, really enjoyed it. And then I got a chance to go to Mayo Clinic, actually, in Rochester, Minnesota, for a year where I did cardiac imaging at a time when we didn't really have a great cardiac imaging, but I learned so much over there. Yes.
Yes, since Prof, since we're on the topic of cardiac imaging, how did you end up subspecializing in cardiac imaging?
I was very okay. I don't think that's so much by my choice. It's like this. At that time, I'm lucky to have been surrounded by very inspiring people. At that time, my head of department in radiology was Prof. BJ. He was a long-time head of department. And the thing about him is he's a very good mentor. You talk to him, he's very inspiring. He talks about big things, but when it comes to implementation, he's not so good. So he will have this idea and the rest of us will have to go around implementing it. And that's how BJ works. But BJ is also a person who strategizes for the department. So he will say, okay, you do this, you do that, and all that. So my husband at that time was going to go and do his fellowship in cardiothoracic surgery. And we didn't have anyone doing cardiac imaging at that time. And he felt that it was a great idea to lump me with my husband and say, why don't you do cardiac imaging? And I felt like, okay, I mean, if you're going to send me overseas and you're going to allow me to go off, I'll take that. So I went off and did cardiac imaging. And the thing is, when I came back, though, that's the good thing about BJ, because when I said, when I come back, you've got to help me realize, because I can't go and learn cardiac imaging and come back and do nothing about it, right? So he was, when I came back, I kind of said to him, for me to do this, I need to create the services in CT and MR, and so on and so forth. So he made sure that we had machines that could do it. Of course, at that time we had more money, I suppose, or the machines were not so expensive. So we did a lot of training. We trained our radiographers. We started a cardiac list, and that became, that's the history of it. So when I say that I was instrumental, I really meant it. I didn't do it alone, of course. There's a whole team of it. But basically, when I came back, there was no such thing. We had to buy the machine that could do it. We had to learn the sequences. We had to learn. We had to train, meaning the companies that worked. We had to train people to do it, and so on and so forth. A lot of trial and error, a lot of research on it, and so on. Until now, I think most of the radiographers will be able to report cardiac CT, and most of our medical officers will think cardiac CT is coronary CTA. Coronary CT angiography is not something so foreign, because every week you're reporting, cardiac CT. So that's where we're at now. Yes, and we work, of course, when you do cardiac imaging, if you are a radiologist, cardiac imaging is a weird field, not weird in the sense that even cardiologists do it, radiologists do it. So we work very closely with the cardiologist. And because of that, we came up with consensus statement for Malaysia. So at national level, we've come up with guidelines on usage of cardiac CT, guidelines on usage of cardiac MR, and we work together with the cardiologist. So that's where it is. But you know what? I want to be honest here. I am a cardiac radiologist in UMMC, but cardiac radiology, because the cardiologists this is worldwide, not just in Malaysia. The world over, the cardiologists are the ones that actually manage cardiac imaging, and they are the gatekeepers. You understand? They are the gatekeepers. There is something not right about that, actually, because if you are a cardiologist and you see a patient and then you refer the patient to yourself to do a CT scan, if you look at medicine, that's not actually good. And then you interpret and you tell your own self that what you interpret is right. So the other multidisciplinary aspect about it doesn't come in. Do you get what I'm saying?
Yes, I think I sort of get what you're saying.
Yes, but it happens, and worldwide it's like this, and a lot of papers have been written about this. So the cardiologists out there who feels that no, it should be multidisciplinary, because when I was in Mayo Clinic, it was multidisciplinary. The cardiologists looked after it, but imaging was done by radiologists, right? So, and Mayo wants that. They pride themselves on being multidisciplinary because it's the Mayo way. But not everyone is like that. So we always have this struggle between cardiology and radiology. And of course, radiology is going to lose out because we don't see the patient. We wait for cardiologists to refer the patients to us. But I'm not complaining. I'm just telling you this is how it is. And if you want to do cardiac imaging, I would say don't do cardiac alone. Do cardiovascular imaging, and that would be a path to go, because we are seeing more and more vascular disease. So so that would be a way to go. But first choose radiology before you even think about something else.
So that's very fascinating, Prof. Okay, sorry. For anyone who has just joined, just to fill you in, we are having Prof. Yang Faridah, our Deputy Dean tonight, who is just giving us her insights on her experiences in joining radiology. She was talking a bit about how she ended up specializing in cardiac imaging. So since we are on the topic of, as Prof, you mentioned, cardiovascular imaging, I just want to delve a bit into something that I just recently came across, which is interventional radiology. So what is it? And is their training different?
No, okay, wait, let me tell you. Interventional radiologists are the superstar of radiology, okay? They are the superstar because, let me tell you, when I joined radiology, I wanted to be an interventional radiology. Yep, definitely, because, they are the ones that they don't just diagnose, but they treat, correct? Okay, so what interventional radiology does is they are like the surgeon of non-invasive treatment. Okay, so like the cardiologists, they would be the ones that put in stents for narrowed vessels. that would, if you have a vessel that's bleeding, let's say you've got a GI bleed and they found a vessel that's bleeding, they'll put coil, they'll embolize. Tumors, if you want to shrink the tumors, you actually can embolize the vessel, make it smaller before you remove it, for example. Aneurysms, now it's coiled, a lot of it is doing coiled. And as you know, Prof. Khairul, our head of department, is the stroke guy. So if you manage to come to the hospital for, within 4 hours of diagnosis of stroke, where you can see, you actually saw the person like from normal to part stroke within 4 hours. And if you are young enough and have all the criteria, they can actually suck out the thrombus from the vessel in the brain and suck it out, and you will regain, almost all of the function. That's how such a superstar they are, So I'm not saying surgeons can't do that, but there are certain times when even surgeons they've created a very good unit. If you create good unit, they will know when it is a radiologist, interventional radiologist time to do it. When is it that is surgery time to do it? So that's the beauty about being in a multi-center like UMMC, where we are not governed by how much money I can get out of the patient. I'm not saying doctors are like that, but you know what I mean? Money is not the issue here. It's the best treatment for the patient. So we will have multidisciplinary team. So our approach is always not what I want to do, but what is best for the patient, decided by a team. Like I've mentioned, Mayo Clinic was like that. And I'm happy to say most of the time UMMC is like that. So whatever decision we make, it's a group decision, it's a team decision. So those are intervention radiologists. Do they undergo different training? Previously, no. Previously, what happens is that all of them have to be radiologists, and then you go for added training. So like for me, I could do cardiac imaging in 1 year and come back and call myself, yay, I'm a cardiac radiologist, right? Now it's not the same. Now all specialty, let's say you do radiology, if you want to subspecialize, it's another added 3 years of subspecialization. And that subspecialization you choose, either you want to musculoskeletal radiology, you want to pediatrics radiology, breast or women's imaging, neuro imaging, interventional. Now, when you do interventional, you've got to choose. Either you want to do neurointerventional, peripheral vascular disease, and all the central bits of interventional. Most people can do the bread and butter stuff of interventional. Even normal radiologists can. Part of my training was interventional radiology. So if I have a patient with hydronephrosis, for those of you that might not have gone through clinical years, hydronephrosis is when the collecting system is blocked by either tumor or a stone, and it is dilated. We actually can put a tube through using ultrasound. So we visualize the dilated kidney, and using the ultrasound, we guide a needle through and then put in a drainage tube. So most radiologists will be able to do the simple stuff, like you want to drain an abscess, cyst, those kind of things we can do. But the super specialized stuff, like what Prof. Khairul is doing, that one you will need the 3-year training to be a interventional radiologist. But they are the superstar. But they are also people who are very similar in characteristics as surgeons. The A-type personality. And so they'll be the ones, like, if things are not happy, and they'll be throwing things out all the time. But and we're gonna, okay, what to do? Interventional radiologist, like, I'm just. But they're very nice people. I'm just pulling your leg, but you get what I mean. Sometimes they can be a little bit of a diva. Yeah.
I see, Prof. Just
I
to,
wanted to be an interventional radiologist, but I again felt in the end that trying to solve the puzzle and I prefer that bit of the work.
so for just to process, it's like interventional radiologists, they go through radiology training and then they further subspecialize in a specific field, which and they also choose to be interventional in that field.
Correct. If you do general radiology, you are exposed to interventional, but not to the level that you need when you specialize. So what I'm telling you now was what was happening before, but there is a move now from the interventionalist in which they want to shorten your training. So you just do maybe 2 years of general radiology or 3 years of general radiology, then another maybe 3 years of specialized interventional radiology. We're working out now how to do that. We're trying to get the sweet spot of doing, and radiology not the only ones doing it. Even people like cardiothoracic surgery now wants to try and do a program in which you do only 2 years of surgery and the rest is in cardiothoracic, for example. But that would mean when you register in the National Specialist Registrar, you can only do interventional radiology or you can only do cardiothoracic radiology, whereas the previous system took longer, but you can do the general stuff because you were trained in it. Yeah.
I see, Prof. It's like
So, but there is a move now into a lot of specialty in trying to shorten it, like pediatric surgery, rather than having to go through normal, surgery or pediatrics. They now usually they go through surgery. They now have like a 2 years general plus maybe 4 years of specialized ped surgery.
I see, Prof. Okay. So it's like in general moving towards a more specialized, more specializations instead of general.
Yes.
Pathways. Okay.
Because previously when we used to do it, yes, I say you do 4 years of radiology, for example, and then you do another 3 years. But the problem is to wait to do radiology, you're already waiting. And then after you become a radiologist, to do your specialty, you again have to wait. So even though it's 7 years, but if you plus all the waiting time, it can take you up to 10, 11 years to finish your specialty. So we as a medical fraternity have realized that this is impossible. It doesn't work. I mean, you can't expect, doctors like you to wait for a long time. So we are trying to make it better for you by doing that, by trying to, make you decide early, but you have to decide early then that's what you want to do. But the option of being a generalist will still be open to you, of course.
Okay, Prof, since we're on the topic of diagnosing in radiology, with this rise of say artificial intelligence or even like more and more advanced technology coming up, I'm sure Prof, you probably heard about how like fields like radiology itself, like the diagnostic areas of radiology, that they are at risk. That they're at risk of being as in artificial intelligence systems are able to diagnose even perhaps better than a trained radiologist, if I'm correct. So how would you anticipate the role of radiologists changing, or is it like under threat, I would say?
To tell you the truth, as a radiologist, and because I did mammography when I had the time, when I was not the deputy dean. So I used to be in the team of the people that did breast imaging. And when we did breast imaging using mammogram, we already had a CAD system, a computer-aided diagnostic system that will pick out the micro calcification or pick up any calcification on the mammogram. Yeah, so they will pick it up. But the problem is perhaps it was not so well designed or whatever, but we had it. And there were so many papers that came out about CAD. And most people will use it as one reader is the CAD, But another reader must be a radiologist, and they both come together, and they then come up with a consensus, because most country with a very vigorous screening protocol, they don't have enough radiologists. Rule of I'm just going a bit into mammography here. The rule of screening mammography, you have to have 2 radiologists reading a screening mammogram. But most countries don't have enough radiologists to read. So they've agreed to make one CAT reader and another one is a radiologist. So basically one AI reader and one radiologist. But the problem is, this AI picked up all classifications. They didn't care. They just picked it all up. So you still need a radiologist to kind of cast an eye and say, well, yeah, but this does not fall under the the worrying microcalcification. It's not branching. Doesn't fulfill the criteria of something that you need to biopsy. So I've already been exposed to AI, but I would think, like, for any other specialty as well, for example, pathology, we have to remember that AI in the end is still just a tool. And tools are things we use. It is a tool that will make sure that we perhaps have less mistakes. And that's very good. I think that's very good. If you can have a tool that can make the diagnosis tighter, that we don't go astray, it really helps us in making evidence-based decision. That's very good. But in the end, the patients do not want the tool. The patients want you to stand beside the tool and say, I've looked at the tool says this, and I agree with the tool, looking at you, your pain is here, right? Touching the patient, feeling the patient, talking to the patient, right? That's what the patient wants. The patient wouldn't want a tool. So I think we don't have to worry about AI. I think we need to use AI. I think we need to learn to humanize AI and humanize the technology. I think that's very important. And that should be in our medical syllabus. Now, we've got to do that. And you know what's more important now? It's super important for you guys, when you are doctors, to be able to talk to the patient. Because if you're going to be as cold as the AI, they'd rather have the AI who's not making mistakes, right? So be warm, all those things we tell you about, empathy, whatever. You really have to not just do it, but really feel it, because that's going to make you different from the AI. And that's important. And we need to put it into our curriculum. I think we need to put patient safety into our curriculum. We have to put, how to use technology, because in the end, they are like computers that you have. Yes, I get that certain jobs will be taken away because of these AI, certain jobs. I don't think it'll be doctors. And I don't think it's going to be radiologists, because in the end, as accurate as the system is, you'd still want the radiologist who can tell the difference between patient A and patient B, and in how they present. You'd need a radiologist to be able to say, yes, I know that this thing says this, and I kind of agree, but there's this aspect to it that I think we need to be worried about. So I would feel that we make AI in a part of our team, use it. It's still a tool. In the end, it's a tool. But like I've mentioned, we need to be more charismatic. If we're going to be as dull as the tool, then of course, you're not going to be a good doctor anyway. They'd rather go to AI. But we have to have that. It's like, I've said this before, if any one of you can remember, it's like when you call the bank and you get that machine telling you, key in the number, and you just want to get to the person that you can talk to, right? You're forever like, get me the person. I don't want to talk to you. Stop asking me to put in my 6-digit, whatever. You get very frustrated, because when you go to the bank, when you call them, you have a problem and you want to talk to someone. And patients are going to be like that. They will want to talk to someone. And that's where We make the difference with AI. So be very clear. AI is there to help us, and it is good because they don't get tired, they don't make mistake, and that's fine. That's fine. So, make sure that our evidence-based decision making is the best that it can be without errors. But it is still a tool. That's my take in it. Yeah. And not just for radiologists, but for pathologists, microbiologists. I think it's all the same. Yeah.
Thank you, Prof. It was definitely as I can understand, it's about as our world gets more technologically advanced, what makes us like important in that equation is essentially what makes us human, and it's so important to
I could not have said it better.
yeah.
Yes, I could not have said it better.
Yeah. So without further ado, so just to sum it up, before I pass it on to Vanjet, who's going to talk about ask Prof a bit about like the pathways into training for radiology. Just to sum up, anyone who's just joining us, we have Prof Yang here, who's our Deputy Dean of Undergraduate, who's also a consultant radiologist. For the past half an hour, we were talking about a bit about radiology itself, where radiology as a field is going, and also about Prof Yang's inspirations and how she came about into the field of radiology. Okay.
Yeah, thanks, Ian.
Over to you, Vanjet. Yep.
Okay. Yeah, I think Prof Yang, you have been very inspirational to all the students, and your emphasis on the human touch, especially in radiology, has been really amazing and eye-opening. So let's take a step back from all the subspecialization, and for all the inspired medical students who want to become radiologists in the future, what are the pathways available for students who want to pursue a career in radiology?
If you want to pursue a career in radiology, there are several pathways. You should, it depends. If you want to be an educator, then you can join university, and usually universities will have the programs for young academics. They are either called SLAP, those are for Bumiputra, or SLI for non-Bumiputras. And we will have openings every year. For example, in radiology, this year we have one SLAP and one SLI. Okay, so we are looking, and you come in before your master's, and when you are accepted into a SLAP SLI program, you then do masters with us paid by University Malaya, for example. But other university does that as well. So university is one route to go. Second route to go is through ministry, of course, Ministry of Health. I know that road is now becoming quite difficult with a lot of medical officers not getting the TAP, right? They're not getting full time. They're getting contract. We as quite a number of people at the faculty, including Kevin from anesthesiology, we're working very hard to try and make that better for you all. But it is still a route for you to go. So if you stay with KKM will have will let you go for cuti, belajar, and you can join whatever training that you want. If send you for masters, you can also stay in KKM or anywhere and take the fellowship, which is the UK exam, Royal College. Now, but the fellowship needs you to be in a radiology department or need you to be exposed to radiology, not the part 1, but the part 2. They need you to have exposure to medical physicists and all that. Yeah. So those are some of the ways that I can think of that you can join. So either you do a master's program in radiology, or you go and do a fellowship in radiology. Previously, we've had people that go to Singapore because Singapore will be taking them in and join the masters in Singapore as well. But of course, I'm not going to tell you all to do that because I want you all to stay in Malaysia. So I would say these are the 2 ways of doing it. These are the 2 major ways. So you can join university, do masters paid for by university, but after that join the I'm sorry, you joined the medical faculty. Yeah. Oh, I forgot one more route. We've had people who joined as medical officers in UMMC. So these were our students. They were medical students. They were then absorbed as housemen. They then did very well, so they were targeted to stay on. So we took them in, paid by UMMC basically, but basically UMMC didn't pay. UMMC paid their salary, but they could do masters with us, and they now continue as specialists in our department. We have about 3 of them with us, and later on when they want to join faculty, they can choose to switch. If we have a job, we have the warrant for it. So if they don't want to switch, they don't have to as well. So does that explain to you how you can do radiology in Malaysia?
Yes, very clearly. And I think the last option, wow, that's a really great opportunity to be able to join UMMC. But
Yeah.
Yeah.
Yes.
It's a
So
really great opportunity.
you
Yeah.
probably, those are your seniors. Yeah, they are there. They're now specialists.
Yeah, I'm just
But
a bit
even if
curious.
you join through UM under SLAI, you still do. You still work in UMMC actually. Your employer is just now UM rather than UMMC. That's it. It's, you work together anyway. Yeah.
So on the
Okay.
topic of that, is there any particular criteria to join the SLAI program?
No, I think the criteria is that you have to have an offer. You have to be offered a place already. So when we are given an opportunity to have a slab and a slide, we're actually looking at possible candidates in the people that we've already brought in, that we've already accepted into the program. However, saying that, because these things are planned, you can approach us earlier and say, I fulfill the criteria to do masters. I do want to do, is there any opening? I would want to come in as a slab or slide. You can do that. You approach the head of department, say that I'm a student from UM, and most of the time we do entertain. If we have the slots, we do entertain. We do want to keep our own students, so you will get priority. Okay.
Yeah. So that's covered for the slide pathway. So my question here is, what are the differences between the master's program and the parallel pathway? And which one would you recommend to students?
Okay, I would recommend the master's program mainly because our master's program now, we're moving into a national program in which you go anywhere in Malaysia, you're going to be taught the same way, the same content. In fact, UKM and UM, both UKM and UM, because we're so close together, we even share the lectures. So some weeks you will be going to UKM and a UKM lecturer will teach you. The next week it'll be a UM lecturer. And when it's exam, we all join together and we all, we inter-examine each other's candidate. So basically, when you join a master's program, you are getting, although your degree is Masters in Radiology UM, but you are actually a national radiologist because everyone undergoes the same training. And the thing about parallel program, the parallel program, you might be able to do it maybe a little bit faster. However, nowadays, with a lot of emphasis on workplace-based assessment, a lot of emphasis, I'm talking about standards. For you to be seen as a specialist, there's a lot more you need to do. So if you do FRCR, the fellowship, you will then have to wait another 1.5 years, if I'm not mistaken, before you can be a specialist. Whereas if you join a master's program, you only have to wait 6 months before you can be gazetted as a specialist. So that's the give and take. And also, if you follow the fellowship program, there might be things that you cannot prove that you've done. So all these things are now going to become very important. Logbooks, your workplace-based assessment, and all that things. It might be a little bit more difficult for you to do if you follow the parallel program. Furthermore, most of our master students will sit for the FRCR at the same time. So they do the 4 years masters, and yet in between they sit for the FRCR. So they actually graduate with both masters and the fellowship. So I would say if you have an opportunity, go for the master's program, because I feel that it's the kind of program in which, especially now we're moving to the national postgraduate curriculum. It is very rich. It ensures that it's really outcome based. It ensures that you are competent a lot more compared to previous ones. So I would choose to do masters, because at the same time you can sign up for your fellowship and do your fellowship together. Yeah, so that's what I would do. And also, because if you do the fellowship, your gazettement is longer.
I see. So just to give our audience an idea of how the scenario is in Malaysia, how competitive is the program for the master's program on radiology, the entry?
Very competitive. We get so many applicants, because in the end, right, for you guys are what? You guys are Zoomers? You guys are Zoomers? You're born, you're Zoomers, right? You're the Z. You guys are called Zoomers. Anyway, the Z generation, you know nothing but computers. So a lot more of your generation, granted, they're now worried about this AI aspect, but they're very taken with the fact that we work a lot using computers. You know, we are doing processing, and you know, so we do get a lot of applicants for radiology. They like it, and of course they are very attracted to this superstardom of interventional radiology. So compared to medicine, internal medicine, we actually get more people applying to be radiologists. AI notwithstanding, it's a favorite program. It's one of the favorite programs. We easily can get 20 master students each year, no problem. Yeah, the limitation is just how many lecturers we have, because of the supervision bit, you know. So the ratio, we cannot have too many of the ratios. So yeah. So I would say it is competitive. You will have to sit for an entrance exam, and you compete with everyone, and you will be called for an interview. That is that's every center that gives a program is there for the interview. So it's a conjoined interview, and we then decide which applicant will go to which center. However, if you are under slap and slide, you will still go through the same process. You still have to take the exam and interview, but you know, if you have applied to UM, you will come to UM, of course. Yeah.
So besides UM and UKM, which other institutions offers the master program for radiology?
UM, UKM, USM, UPM, UIA, and I think UITM, as well as KPJ, which we are not happy with. Sorry. But you know, they've managed to snuck in, and we're going like, why? Because they can't even train them. I mean, they don't have enough patients. I can't imagine their patient wanting ultrasound to be done by a trainee. Like, I've paid so much, why are you touching me? You know, that kind of thing. So they are having problems. So try and avoid those private universities. I think if Malaysia can do it, it'll be very good. Like Mayo is actually where I went to train for my cardiac imaging. It's actually a private hospital. But US works in a different way. It's a private hospital, and yet they welcome trainees at all levels. They've got medical schools, and the patients are okay with it. The patients like that, like that it's a teaching hospital, because they feel that if it's a teaching hospital, then you really have to practice evidence-based medicine and evidence-based decision making. But our country, we're not there yet. Yeah.
Okay, so there has been a lot of talk about the pathways and everything. So just before I hand this session back to Ian, Prof. Yang, would you like to share about your experience in the UM Master of Radiology program? How was it like? How was your studies? How was life as a master student of radiology?
Oh, I really enjoyed my radiology masters. I think I've mentioned this. This was when I finally realized that I'm not such a bad student, that I actually can know stuff, because suddenly it makes sense. Funnily enough, anatomy for me, when I learned it as medical school, it was so hard for me. And yet, when it comes to radiology anatomy, it just clicked, it just clicked for me. I don't know why that happened. So I felt that I was a pretty decent student, and by the time you get there, you are older, and you do get that teamwork is very important. So we had such a cohesive group. There was only, how many of us? There was 6 of us. And we still meet up until now. We still go for dinners. We still, very much in each other's life. And we used to do everything together. We used to eat together, we used to go to the library together. We answer questions, so we'll divide ourselves into that. So in terms of learning, to me, it was very enriching. It was such an enriching experience. Working in UMMC was a little bit tough, because we had many patients, and I think now we have even more patients. It was a bit tough, but that also gave the patients became the tool for me to learn from. So I really enjoyed that. And as I mentioned, I had very inspiring people. So BJ was a good lecturer. The lecturers that I had were very good, and towards the end we kind of became friends, because they knew that I was going to join. I was a SLAT candidate, by the way, so they knew I was going to join the university. The only thing was that during that time, our calls were using pages. So, and we didn't have a room to stay in the hospital. So we'd have to drive in and out. Whenever we get a call, we have to come in and report. That can be quite scary can be quite scary, because you're walking at night and sometimes things are very quiet. So I felt that was a little bit difficult for me, I felt, because of the perceived sense of danger. But apart from that, it was a wonderful program. I think I had so much fun. It all gelled for me, I felt. It came together. And during that time when we were doing masters, we were already teaching medical students, and we were teaching our juniors. That is something I think that's a bit lost, that has been lost now in the master's program, which we are looking at putting in again in the national curriculum, making it like, remember, when you graduate as doctors, it's in your oath that you share knowledge, continue to teach people, So we want our graduates from UM specialty program to continue that, to teach each other, to teach the juniors, to teach the medical students. We want to bring that back, because that's what we used to do. We used to take medical students I used to have sessions with medical students, even as a medical officer in radiology. And I think that's how you learn best, because when you have to teach someone else, you really have to know your material. And that's actually the key. Sharing your knowledge will make you better at that knowledge. That's how I feel. Yeah.
Thank you,
So
Prof.
it was like, come to the faculty, come to the department. We had such a fun department.
Yeah, I can tell from all the smiles and all the stories that you shared, you really enjoyed your
I really
journey
did.
in this program.
But there is also how you view things. If you want to view things as hard, it's going to be hard. But if you want to view things as challenging, but I'm going to try and enjoy every bit of it, then it will be so. So how you go into it matters. The people and people want, you know, we help each other. We were in that together. We wanted every one of us to pass. So we were very committed to that. So we were so close. We were such a close bunch, very close. And I really, really enjoyed that, much more than my medical school, I'm sad to say, but I really enjoyed having friends like that. Yeah, that was good.
Thank you for sharing with us, Prof. And I was really happy to share some of your happy memories. Back to you, Ian, on the medical education aspect.
Hi, yes. Yeah, thank you for sharing, Prof. We are running a bit behind schedule. I'm just going to delve straight in just to ask a bit about what exactly is medical education, since you have been involved in it, if I understand.
Yes. I became involved in, I mean, because you're a lecturer in an institution, you are already involved in some form of education, correct? And as I said, even as a medical officer, I was involved in education. But at that time, it was more like just as a lecturer. And at that time, nobody trained you. You're not trained. You just inherently have to learn how to be a lecturer. So now this thing has emerged where medical education becomes actually a path that you can take, like almost like a specialty that you can do. And when you do medical education, it's a lot more than just being a good lecturer. It is about training. It is about looking at methods of assessment. It sounds boring, but it's super, super important. Things like I've said to you, what should be in the curriculum? How should we view 21st century medical education? How do we empower our students? How do we bring in things like self-directed learning? How do we reduce the hidden curriculum in the faculty? All these things come together. So, but of course, the core bits of medical education will be curriculum content. They talk about having an outcome-based curriculum, student-centered. Assessment must be all aligned. Yeah, it's all these things. I know it sounds quite boring, but when you get into it, and you're doing curriculum, there is something very, how do I want to say it? I didn't know how exciting it could be until I was made the deputy dean, and I had no choice. I had to go into it. And now I find as if I find that while I love to teach, but at the same time, I also like to think about design, think about how we want to make it better for the student. You see the problems and you've experienced the problems as I was being taught before, and you know that's not the way we want to do. So, you know, when we tell you that we want you all to be empathetic, yeah, we want you to have all these qualities, but are we ourselves showing it to you that you should have it? I don't think we are. So there's a disconnect, there's a gap to that, right? So when we tell you all about patient safety, or when we tell you all, let's say patient safety, are we doing it ourselves? I feel medicine is a lot of role modeling, which you may not realize. And as students, it is also your duty to know who you should follow and who you should not. Because as much as you have good teachers out there, you have equally bad teachers. So you have to make that decision. But us in medical education, at least, we can make sure that the structure of the program is there for you, the structure of it. And we must make sure that you learn in the best way. The problem with medicine is we cannot teach you everything, neither can we teach you, neither are we computers that we are able to tell you, if you have a patient with A, B, C, D, these are the questions you must ask and you must not miss it. It's not like that, because it depends on how the patient comes and all that. So for you to teach you to make that judgment is actually difficult. But if you do it the correct way, if we show good, if we make sure that our academic staff have positive attitudes and are really, sincere, honest doctors, you all will see it and you all will learn from it. So to me, I feel medical education was not a field I wanted to get to on my own. It was thrust upon me by Prof. Adiba, actually, and but I felt that I actually like it. I'm embracing it. And now I'm doing a master's in medical education just to put a paper to what I've gone through the last 6 years. I wanted a paper qualification for it because since I've done it for 6 years, I just want to make sure I have a paper qualification from it. So I hope to have a MBBS Malaya, Masters of Radiology Malaya, and a Masters in Medical Education Malaya. So I'm going to be like, this inbreeding kind of person at university. or we prefer to call ourselves thoroughbreds. Well, that's what I'm planning to do. So yes, medical education, very interesting field, but I feel, this is me personally, don't tell everyone, but I feel that if you are a doctor, for you to do medical education, specialize first, do a specialty first, and then come into medical education, because that would make it more enriching for you and for your students.
Yeah, Prof, from how you describe medical education, it sounds more like you're taking up a policy role, like more of taking more like a policy making role, like looking at the grants.
Not at all. You can do policy, but no, actually it's not. Any one of us can do medical education. The people in my department who are doing these, who are working on the national curriculum, they are not medical educationists. They're specialists. But because you're a specialist, you are able, and because you're a specialist, number one, so you practice the craft. Yeah, you practice the craft. Secondly, there are now theories in education that has come across that has made it easier for you to understand how we should be training the next generation. So it's not policies at all. It is not, you can choose to do policies, but most people don't. Most people actually actively think of how I can create a curriculum. And when we talk about curriculum, it means from even before you enter, how do I get you to be interested in this, right? So a perspective, like what kind of applicants do we want? And if you are one of them, come in. So from there to the entrance exam, to intake and training throughout, how you progress, that's medical education. How do we want to say, I want you to be a doctor at the end of first year, what are the competencies that you need to have for you to progress to second year? And we have to make all that very clear for you guys. So it's not about policy. It is actually about how to train. And part of that is training the trainers how to train. So we need to train the doctors how to train. So we're doing like a massive exercise for postgraduate where we hope to train all doctors in Malaysia to train. So if you do radiology, you don't have to stay in UM. You can be in Batu. If there's a radiologist that's been trained to train, the person can train you. And that's how it should be.
So Okay, Prof. So like this medical education pathway is different from the SLAP pathway that you mentioned, is it?
Yes, the slide pathway is not going to be for medical education. The slide pathway is going to be for a specialty. Yes, yes. But what some of your friends have done, your seniors, what they've done is, because after 5 years of medical school, you have to wait a while to get your housemanship. So some of them have been waiting like 13 months. So there's some of you that, because with MBBS, you can actually do a master's. So they've done I think one of them is doing a master's in education now. Several of them has done a master's in science, doing a research, and they've done fantastic, right? So our students are graduating. By the time you get to be houseman, you have MBBS and a master's in something, because most of these master's programs take a year. Not clinical masters, but master in medical education, definitely. Masters in public health is a year. Masters in medical science is a year program. So those are things that you all can take. So if you want to do medical education, something you're interested in, you can actually do this 1 year masters in medical education while waiting for your housemanship. And then do your training specialty. Or if you really don't want to train in your specialty, you really just want to do medical education, just finish your housemanship, then do medical education. That's fine as well. Yeah.
I see, Prof. So staying on the medical education path, so what are the pathways available for any students who want to go into medical education?
As I mentioned, with your MBBS, you can do a master's in medical education.
Okay.
And it's just a 1 year program in UM. It's just 1 year. Following that, you then, the thing is, if you don't do your housemanship, you will not be considered as a registered practitioner, though. And the thing about medical education is that for you to really be able to understand what training is needed, you kind of need to have the experience of being a doctor. You get what I'm saying?
Yeah. Yes. As in, you need to be in the field before you know how to like improve on the field, or improve on the system itself.
Correct. If not, then you can be, we have medical educationists who are not doctors, but who are not medical doctors, but then it becomes very, you're just looking at curriculum for curriculum's sake. You will not be able to see the nuances of how this particular training path, this particular way of training would be better than, because for you it's like, well, the book is to do this, but you don't have experience. So I would think having clinical experience would make you a better medical educationist. But that's not to say if you are not a doctor, you can't be a medical educationist. I'm not saying that. We need statisticians, we need study designers, instructional designers, and all that. But I feel that it does make you better trainer. You understand it better. Yeah, does give you an edge.
I see, Prof. Okay. Just like to switch tone a bit and move into perhaps ask a bit about work-life balance. I guess so. Personally, as juggling so many roles itself, or even as a radiologist, first and foremost, what are some challenges that perhaps, Prof, you would have faced or have faced in balancing like the various roles in your profession and also in
The thing about work-life balance, in anything that you do, anything actually, I would say anything that you do, but especially in a professional career, don't expect to have work-life balance in the first 5 years of your life. If you expect it, you're going to be disappointed. Don't expect it. Or rather, don't expect it until you finish your specialization, perhaps. Because, and that makes sense, because your time is not your own then. You're doing a training, you have to do on calls. You have to you have to be on top of your game all the time. If you have an expectation of work-life balance at the get-go of your career, you are going to be disappointed. You are going to say medicine is not for you. Life is so unfair. Boo hoo hoo. Don't. Because anything you do, even my son, who didn't do medicine, who became a software engineer, worked in a company, my God, it took him a few years to realize that, okay, it's fine, because he would, whenever they've got a project, it's like all-nighters, right? And they work very late. The only difference is that he can go to work in jeans and t-shirt. But the work, when I look at how he works, I say, you might as well have been a doctor. You're working so hard. And he said, yeah, I've got this client, I've got this. So reality is that I don't think if you are going to do meaningful work, anything that you choose, you're not going to have work-life balance in the beginning. You're not. You just have to accept that. But the beauty about it is, as you become older and you actually are paid more and you're able to appreciate that extra payment, then somehow the hours that you have to put in decreases. Your responsibility increases, your accountability increases. As a consultant, my responsibility and accountability is high. But in terms of hours, I no longer have to come when it's on call, for example, right? Because I've got the juniors to do it. So that's when you actually have the life that you want. A little bit of balance. If you were to look at even surgeons, if you are not operating, if you do not have clinic, your time is very much your own. I mean, you've got to go and see your patients. You've got to make sure that they are okay. But after that, you're not on call. You can go home and spend time with your family. So my take on this is, anything you do, don't expect work-life balance on the get-go. It's never going to happen. No profession will give that to you, because in the beginning, that's when you have to be trained. And then when you are trained and you are able to show that you're responsible, that's when things get better for you. So accept that. Life will be much better for you. But not having work-life balance doesn't mean that you are upset all the time. In between, grab whatever piece of happiness that you can find. Maybe not happiness, but maybe contentment. Like, I went through masters. It was very grueling, but I had my friends. So we'd go for coffee, we'd do things, and we arrange for movie nights, for example, just short stuff that we do. Or even alone, I like to read. I love to read. So for me, it's like, if I'm having a terribly tough day, I would say, it's okay, I can go home and read 3 chapters, and that's going to be my present to myself. And that can just calms me down, and that actually creates, I feel happy knowing I can anticipate something that's not so bad. So do that. You really have to adjust. But don't expect work-life balance at the get-go. I actually did my master's and had 2 children while I was doing my master's. That was tough. That was really tough. And my husband was also doing training. But we survived. I don't know whether my kids are that okay. My youngest son, I got him when I was already a lecturer. I think he's better adjusted. The other 2, it's a bit like left alone all the time kind of thing. But they're okay. They can talk and, feed themselves, so they should be okay. Yeah. I'm just joking. They're all right. They're fine. They're fine boys. Yeah. Yeah.
This Prof definitely got the message. Yeah, if there's in any fulfilling or like doing meaningful work, yeah, it's work-life balance shouldn't be the first thing you think about. That's the, yeah, I guess it's the message that we across. With that said, Prof, shall we move on to Q&A? I'm pretty sure that, yeah, we've been listening to both of us talk about, yeah, asking you questions for the past 1.5 hours. I'm pretty sure our audience would have their own questions as well.
Go ahead. Yeah.
So, yeah, I'll just pass it to Ranjit.
Okay, sure. Here's a question from Mirza, who is also a medical student from UM. Good evening, Prof. Regarding the SLAP and SLIDE program in other specialty pathways to continue with masters, one would typically require the HLP to fund their studies as well as to prepare them to have a working position once they graduate. With now only about 3% of HOs being offered permanent posts, this may pose as a problem for applying for the HLP. Will the same issues with the contract system and permanent post affect the SLAP and SLIDE entry?
The thing is, SLAP and SLIDE is university based, and your hadiah belajar comes from KPT and not from MOH. It comes from MOHE, Ministry of Higher Education. It doesn't come from MOH. I get what he's talking about. Hadiah what was it again? HLP, hadiah latihan, HLB, hadiah latihan belajar. That's what I said. That's the normal MOH pathway, Ministry of Higher Education, Ministry of Health pathway. That's the one that is in trouble now because not many people get, like I said, you don't get, most of you will get contract post and you do not get a permanent post. And those who gets permanent post gets the hadiah latihan belajar. Okay. SLAP and SLIDE don't fall under that. SLAP and SLIDE is a university based how do I want to say? It's university. It's under university and it's given by Kementerian Pengajian Tinggi, MOHI. Oh yeah, definitely. I agree with you. It will affect. Would the contract HO issue affect SLAP and SLIDE? I think it will affect, and I think it's already affecting it now. I agree with you. But like I said, we hope to sort things out soon. I know that, for example, our SLAP SLIDE, they are medical officers from MOH and they apply straight to the university. Okay?
Yeah, okay. So on the topic of that, we have another question from Chan Chi Ken. Hi, Prof. Just now, Prof mentioned about UM graduates being retained by the UMMC to work as an MO and then further joining their master's program here. That is considering if they do well as a HO in UMMC. What if we are not selected by the government to serve our housemanship in UMMC? Would there still be a chance for us to go through this pathway?
At the moment, I would say no, there's no chance. But having said that, we are part of the strategic plan of faculty and hospital is to create this seamless transition from student to housemanship to medical officer to a specialist. We are looking at doing that. So the answer for you at the moment is I would have to say no, but we are looking for ways that we can do that, in which we can talk to MOH and say, these are, we want to keep some of our students in the system to follow this way. And the only reason that happened, because at that time we were allowed to keep our students. So I don't know what had happened along the way that had changed that. But if it is a matter of getting the hospital to, it is a matter of us getting our acts together and talking to MOH and also getting MOH to see that this is a viable path. So what I'm telling you now, that option, if you are not given UMMC, that option may not be open for you now, but you are talking about something that we have put in our strategic plan. So we are hoping to work on this for the next year or so. Yeah. I cannot promise you, but I'm just telling you that we've thought about it. We want to do this. So we're working on a system that will work and that's sustainable.
Yeah, I believe Ian has a follow-up question for this.
Yes, I think in regards, probably just a clarification on the slide pathway. Prof, you mentioned it is a pathway that you apply for only after you join a master's program.
This is what that was told to me today, but I cannot confirm it. I was told in passing, just like someone just mentioned it, but that does not make sense because previously, I do remember applying. When I applied for SLAP-SLI, I did not have to have a post, and also when I remembered last year when we interviewed people for SLAP-SLI, they were not offered a post. I mean, they were not offered a place either. So I have to confirm that. And if I have to confirm that, I was just told about it today, but I did think about it and I said, like, how are you going to get a place in masters if you are not full-time in MOH? So if you were given because if it's like this, for you to apply, you need to be full-time MOH. Then you will be given the hadiah cuti belajar or whatever, hadiah latihan belajar. But if you are under MOH with hadiah latihan belajar, how can you be under SLAP-SLI? That makes no sense either. You get what I'm saying? So to me, I suspect SLAP-SLI would be someone you want to bring into the system and they apply directly to UM. But someone please get in touch with me again. I can confirm it. I can talk to bahagian sumber manusia in UM and confirm that for you. And then you guys can let each other know. Yeah.
Sure thing, Prof.
I would think only those who are about to graduate will need to worry about it. All these things, we will try and streamline the process. Yeah. But anyway, remind me about it. I'll talk to the HR of UM and confirm what are the criteria for SLAP-SLI. Okay?
Okay. So, all right. Thank you so much, Prof. I think, yeah, Vanja, do we have any more comments or any more questions?
No.
If we don't, I think, yeah, we sort of come to the end of our session, Prof. I'll just pass it over to Vanja.
Yeah, sure. Prof, I think you have a message for all the students.
Yes. You know what, guys? It has been 6 wonderful years of being your Deputy Dean of Undergraduate. I became the Deputy Dean of Undergraduate because the then Deputy Dean said she's going on long leave and I'm just supposed to memangku her for 6 months, and I totally fell for it. So I said, but you're coming back, right? And she said, yes, I'll be coming back. You're coming back, right? Yes, I'll be coming back. And next thing I know, 6 months later, I got a letter to say, ta-da, you are now the new Deputy Dean of Undergraduate. And I was thinking, oh no, this is really, I fell for that. But no, but I know these are my mentors, and basically they felt that I could do the job. So I then did 5.5 years of being the Deputy Dean, and that has been such an enriching experience for me, being able to interact with the students, being able to talk to you guys, hearing your wonderful ideas. You all are so brilliant in thinking of new things to do, how to do it. And the number of times you come up with surveys, it's like today one survey, next day one survey, and I'm like, amazing. And I do know that we've been instrumental in bringing you guys into University of Malaya, and we take our selection process very, very seriously. And I think we have chosen very, very well. And I'm very, very proud to have been able to be your Deputy Dean and to have worked with you. However, I will have to say goodbye. This is my last month as the Deputy Dean of Undergraduate. I will be leaving the post on the 28th of March. And I just want, as you know, as I mentioned, I'm now going for my sabbatical, and hence why I've enrolled in my Master's of Medical Education. So much as I love to have worked with you all, I think it is time for me to kind of focus on my career for a bit and maybe take a little bit of a break. So I just wanted to say that to you all. Thank you so much for all the support, all the love. I really, really enjoyed working with you, and I hope that we can still work together. I really want to do something on student empowerment, something more formal and concrete, and let's see whether we can do that after I come back from my from my master's. Yeah, we'll still be in touch. I'll still be around, but you're going to have a new deputy dean that's maybe better at the job than I was ever a deputy dean, but that's it in a nutshell. I just want to say goodbye, and I've really enjoyed being your to be the person that you go to help you out with your trouble. And I hope I've opened myself up for that role, and that you felt that you could have come to me with that role. So I hope. So I also want to apologize if I've hurt anyone or said any bad things or done something really bad, because sometimes as an administrator you have to do that. But I've always wanted to put your interests first. So thank you very much, guys. It's been a blast. Bye.
Thank you, Prof. Yang. I think many students will agree with me that, Prof. Yang, you have contributed invaluably to the Faculty of Medicine, and also you have been helping so many students, especially with their studies and their journey in medical school. So on behalf of MEDSOC and all the students that you've taught in the past, thank you, Prof. Yang, for all your contributions, and thank you for
thank you for making it the best 6 years ever. I will never forget what I did.
Yes,
so you guys go out there, zoom away, okay?
Yes, thank you, Prof. Yang. We wish you all the best in your future endeavors, and good luck in your online classes for your masters. Thank you, Prof. Yang, for joining us tonight for this session. We really appreciate it. So, ladies and gentlemen, we have reached the end of our session. It has been a blast having a conversation with our Deputy Dean, and we really appreciate her a lot. Thank you, everyone, for joining.
Thank you, Ian and Benji. Thank you, everyone.